Rajiv Jauhar. I'm the Chief of Cardiology at North Shore University Hospital in New York, United States. My talk will be on the management and treatment of calcified lesions. I think the most important thing that will come out of this talk is the importance of imaging in this endeavor. We know that angiography does not provide a very good appreciation of calcium in coronary arteries. As we know, about 40% of truly calcified lesions are appreciated on angiography, while on the order of about 80% are appreciated on IVUS and OCT. So the purpose of my talk is really to address how and to formulate a systematic approach to the management of calcium, because calcium can present in so many ways. It could be deep calcium in the coronary tree. It could be superficial calcium. It could be eccentric calcium. It could be a nodular calcium. And each of these calcium types are treated a little bit differently. So the systematic approach is really to start with intravascular imaging and use that to guide you to create the largest MSA without any complication. Because we know the lesion prep is very, very important in calcified lesions to maximize the expansion of the stent. To maximize the expansion of the stent. Whether you use intravascular ultrasound or OCT is personal preference, but to not do imaging in these types of patients does not do the patient a service. Calcium is a huge problem, especially as the population ages and the complexity of the lesions increases. Our armamentarium consists of non-compliant balloons, cutting balloons, intravascular lithotripsy, orbital atherectomy, rotational atherectomy. And so we should use the appropriate tool for the appropriate patient in treating them and maximizing stent size at MSA and minimizing complication. I thank you for the opportunity to talk and to present at this terrific forum. Thank you.